welcome to the Peninsula Vet Emergency and Referral Hospital Vet Wrap, a new podcast series where we explore all things veterinary. We share with you veterinary advice, say careers advice. We utilise the whole team, so our emergency and specialist team, to investigate topics and to discuss areas of interest and sometimes case reports that are of excitement to us and hopefully to you. So I really hope that you enjoy this series.
Okay, so welcome everybody to episode 5 of Vet Wrap. My name is Dr. Chris Franklin and I am a surgeon here at ERH, a recently qualified specialist. And I have with me today Dr. Luke Ellis, who is one of our residents. He's in your second year.
Yep,
now?
second year.
Yep,
halfway through.
Yeah. Luke's you're interested in all areas, but orthopedics is your particular love, isn't it?
It tends to be slightly more orthopedics, but I haven't picked a specific area yet. Yeah, right. I'm enjoying taking all the cases at the moment and figuring it out along the way.
Yeah, excellent. We thought today we'd actually discuss really an open discussion, essentially about probably one of the most common second opinions that we see as referral vets, I would say, and that is poorly performing TPLO patients post-operatively.
Yeah. It's really common. You know, we see our own, we see others. See plenty, and they're regular. There's one in this morning. So
it's one of those things that the reason I think it's a good topic is because I feel like it's quite confined. Like it's one of those things that you look at and you go, okay, look, there are commonly 3 or 4 maybe issues that could occur that you need to look out for. And the sort of the particularly the thing that I would start with is the question of why this dog isn't doing well after TPLO is very, very uncommonly because it's arthritic. The answer is very rarely that.
Yeah.
You'd agree?
Yeah, definitely. I mean, I think we both know dogs tend to tolerate stifle arthritis quite well. So it's sort of not even on the forefront of my list of differentials for an issue, as probably yours as well, I imagine. Yeah.
So, Lukey, I think probably where I would like to start is to imagine a 3-year-old Labrador, the one that you operated on 6 weeks ago, 4 to 6 weeks ago, and that dog comes into the clinic for a recheck. What are you expecting that patient to look like as they walk in?
Well, typically, I'll start at the start, I guess. We see those dogs back routinely at 2 weeks and 8 weeks. And often in our discharge handouts, we're expecting that dog to be toe touching and have that leg down by about day 2-3 after surgery. Yep. And then slowly progress in the amount of weight on that leg in the recovery. By the time they come back about 2 weeks after surgery, we're expecting them weight bearing reasonably consistently. Every step the foot's going down. They do have some degree of lameness, but they're reasonably comfortable at 2 weeks, despite being notably lame. And then as we go through and, see those dogs, even we don't routinely see them in between, but typically by about 4 weeks, they're quite sound. They're comfortable. The swelling from the surgery is settled. And these are dogs that are, even walking 10, 15 minutes once or twice a day, tolerating that really well, and they're really comfortable. So you might notice subtle things and that's about it, but they're reasonably sound. Then by 8 weeks when we're seeing them back, a lot of those, it's hard to tell they're lame.
Yes. So, thanks for that. That's a good summary. And I guess this is the point of today's talk is really that in order to recognise that something's going wrong, you have to recognise what normal is, and so that normal that's our normal expectation. So if something falls outside of that, then that starts to trigger a concern that maybe something is going wrong, right?
Yeah, definitely. Yeah. Yep. And as you do more and more and see the follow-up, you sort of generate your own line as to when something's crossed that line and that's abnormal. And as soon as that line for you has been crossed, you need to intervene and try and diagnose what's going on.
Yeah. So you're just going to put you in a picture for a minute. And visualization.
Yep, I can see it.
You 6 weeks ago performed a TPLO on a 3-year-old Labrador to put it absolutely sort of smack in the middle of normal. And ever since the surgery, the dog has really just not advanced beyond maybe the first week. It's toe touching, it's kind of walking a little bit on the leg, but it's clearly not progressing and hasn't really shown any signs of doing so. Can you just start with your maybe thought processes around that case?
Yeah, this is a hypothetical, right?
This is your case I saw this morning, mate.
Look, so the first thing I'm thinking about is that getting that history and exam initially, because in the back of our mind, we've got a list of differentials, and quite commonly the top of that list is a surgical site infection, meniscal tear, some things on there. But there's several other things that are less common that are on there as well, and that history and exam initially may point you in the direction of one complication over another. Yeah. So, I mean, that's the starting point.
Yes.
But
so we might as well put the list out there because we alluded to this. So infections top of the tree?
Yeah, and I guess depending on that history as well, particularly those ones in the short term, first week or two, really struggling when they come back for their suture removal, not weight bearing well at all. I mean, that's probably the top of the list.
Yes.
Unless you've essentially missed a meniscal tear at surgery. Yeah. But, those ones that are doing well for 4 weeks, 5 weeks, acutely lame or quite markedly lame, that might point you in the direction you're looking for a meniscal injury rather
so that'd be second on the list would be a meniscal tear. Late meniscal tear can be as early as 2 or 3 weeks beyond the surgery.
Yeah.
And then typically you're expecting to see that patient has been actually maybe doing well and then suddenly stops doing so well. I mean, late meniscal tears can obviously occur all the way out to 6 months or 12 months.
Yeah, even I did have the odd one. It was about 3 or 4 years post-op and jumped off a retaining wall. Yeah. So it's possible long term, but it's unusual past 6 or 12 months, isn't it?
But it is important to recognise the possibility that could occur as soon as the dog starts to use the leg.
Yeah, essentially.
And there's always that slight grey area, isn't there, whether that's actually one that you've missed at surgery.
We all think about for a little while afterwards,
Yes. or is it genuinely a late tear? And the reality for the dog is that he don't care.
It's sore.
Yeah. So we've got infection, we've got late meniscal tear or meniscal tear.
Yep.
What's up next?
Well, look, I guess it starts to become less and less common. All those sorts of things that might be associated with technique. Is there residual instability with inadequate rotation of your TPLO, patellar tendonitis? They can fracture the fibula and become a little bit lame. Implant failure is really quite uncommon, but when it happens, it's a bit of a catastrophe. So,
So you've got the dog, you've taken history, you've done a clinical examination. Is there anything particular in a clinical examination that you're thinking about looking for?
Yeah, look, I'm always palpating over the implant. You're looking for a discharging sinus or pain and swelling over the implant. Flex and extend the stifle. Is there a meniscal click?
Yeah.
I do palpate laterally just over the fibular head just to see if any pain there, and I palpate the patellar tendon, and also just the adjacent to the patellar tendon just to assess how much effusion there is. Is there a marked effusion and it's really swollen, and could we have an infection in the joint as well? Yeah.
I think the only other thing I would add to that is whether or not the stifle appears to be stable. So I would like to do a tibial compression test just to see whether when I put the load on, there's actually some indication that the tibia is sort of slipping forwards.
Yeah, definitely.
And so we've got a clinical examination and we've got that list. And that's the list we're going to carry forwards, because the discussion then becomes, what are we going to do to both diagnose that and possibly treat any of those things that we found?
Yeah, yep. And look, I guess it changes what we do initially depending on the period of time post-operatively. Obviously, if we've got an implant-associated infection, we really need that osteotomy to heal before we can consider getting it out.
Yeah.
So,
the plate, that is.
Yeah, the plate, yeah. So, look, if we've got obvious swelling or a draining sinus over the implant, we could stick a needle in and find a pocket, get a sample, and send that for culture and sensitivity. If that's not possible, or getting a sample doesn't appear to be quite as easy as you'd like, we would treat empirically with antibiotics if that appeared to be the most likely issue for the dog. And pending that, we're really waiting for that time frame to extend out where we can take an X-ray, which is, it can be as early as 8 weeks, but often, I find it's closer to 12 before we're comfortable taking the plate out. Look, that's part of the initial investigation.
And with infection, obviously, diagnosis can be more challenging than you think. I mean, depending on the virulence of the bacteria, sometimes you're going to find a dog with pyrexia and discharging sinus and potentially also, unfortunately, a septic arthritis. That there's a big effusion, we should be having a sample of that as well. But other times it's just going to be a small sort of scar tissue, kind of almost like a granuloma or something that's been a thickening over the plate, and it may be a little bit uncomfortable if you're playing with that, but that's about all the evidence that you're going to see, right? It's not always shouting at you, I am infected.
Yeah, really challenging to diagnose some of those cases. And they're often ones that we're assuming they're infected based off a response to antibiotics, aren't we?
Yes. And that is kind of one of those points that I think is the key thing about message that's coming across would be, the first one would be, infections don't always shout at you. And if we go back to the original premise, if a TPLO patient is not doing as well as expected, there will be a reason for that.
Yeah.
And so if we've got top of the list infection because it's probably the most common, but if you've ruled out everything else and literally, you will have done this, maybe wind the clock forward a bit, and you've got the 12, 14-week-old patient, well, week past surgery, not old, and you will actually, you've done everything else you want to do. You've sampled the joint. You can't find anything really wrong with this. The mechanics look fine. It seems stable, but it's not working very well. You've taken a plate out thinking it might be infected and had a resolution, right?
Yeah, definitely.
There's no evidence on the X-rays. There's nothing going on, but they are infected.
Yeah, for that lame dog, 12, 14 weeks post-op, we typically admit that dog, start with radiographs. If the osteotomy is healed, there's no evidence of osteomyelitis on a radiograph. We then tap the joint, no evidence that it's got a septic arthritis. We'll put the arthroscope in, check for a meniscal injury, and when we've sort of ruled out all the things on top of the differential list for complications, we'll often take that implant out, assuming that there's nothing really else that it could be.
Yes.
And there's probably biofilm and a niggling infection associated with the implant, and majority of the time that seems to be the case.
Yes.
You get the outcome by doing that.
Yes.
So
and sometimes unfortunately you don't get a culture either, but it's still the patient improves. So you go, well, it kind of must have been infected. And if you read the papers, the definition of an infection at SSI, one of the definitions is because the surgeon said so. That's
right.
That's it. But they're probably right. If you've got a resolution after you remove the implant. So we've got the dog in. It's almost a when you choose to take action on your poorly performing TPLO is kind of a matter of severity and longevity, isn't it? I think. At some point, you're going to trigger that discussion. You're going to trigger that investigation. It's like, in my mind, it's like a day. Just okay, we're going to have a look, and we're looking at everything.
Yeah. Well, I mean, it depends, like you said, on the severity and how long that dog is out. And I typically expect the dog to be toe touching and starting to weight bear consistently by probably day 3 after surgery, reasonably quickly. And if you get a dog present that sutures out at 2 weeks, that's fairly markedly lame, like that might be the time we intervene then, because waiting extended periods of time is, the longer you wait, the more muscle mass that dog's, and the outcome is essentially suffering. So you probably share the same opinion, I imagine. Yeah.
And I think it's difficult. It's easier for us, I think, with specialists when you can pop a scope in. It feels like a minimally invasive thing to do. to actually just pop a scope in and see if there's a meniscal tear. I mean, obviously 40-50% of the time you might be able to feel a click, and that's a really good indication there's probably something on with the meniscus. But once you've got beyond the point of thinking, I don't think it's infected, I need to look inside the joint, I think it still comes back to that same discussion that this dog is not doing well, it is in pain. So even if you don't have an arthroscope, it is appropriate to consider mini medial arthrotomy and go and have a look.
Yeah, definitely.
You have to find the source of the problem.
Yeah.
Because the surgery was originally for a dog who was reasonably lame. And if they're exactly the same as that,
yeah, you're expecting improvement. And when you've convinced yourself that something's wrong rather than it's a slow recovery, well, that is the time to intervene, isn't it? Yeah.
So I don't think it's inappropriate at all to just open the joint and have a look, at that point, even if you can't perform an arthroscope. And do it minimally invasively.
Yeah, definitely. A mini arthrotomy is not super invasive either.
No. I guess we probably jumped over the possibility that you've looked at your post-op X-rays and then your second set of X-rays, and are the angles appropriate for actually performing a TPLO, which is a really hard one, especially if it's your surgery, to look at it and go, being honest, did I do what I set out to achieve?
Yeah.
And has it healed in that way as well?
Yeah, well, I mean, we've all been there. And I would even say after many, many hundreds of them, we're aiming for 5 to 6 degrees with our TPLO. How many do you get where you measure it and go, oh, that's 9, that's 10? It happened, maybe not you. Yeah. I mean, I still find quite regularly, you're talking half a millimetre to a millimetre off your rotation in some of those. So.
And obviously in smaller dogs, particularly if you're because your curve cut is relatively a millimetre on a curve cut, if you're doing a 12 millimetre TPLO, is I did actually work it out once, and I've now forgotten what that is. But
I don't know off the top of my head.
It's 2 or 3 or 4. It's 4 or 5 degrees. It's a lot more than it would be if it was a 30 millimetre cut and 1 millimetre.
Yeah.
Because it's just relatively angles change.
Yeah.
And so it's easier to make a mistake on a smaller dog. The good news is that small dogs are probably slightly more forgiving.
Yeah, definitely. I know I really like doing TPLOs in small breed dogs. I think they do really well because it take us on to.
Yes. That's the thing. It's a whole different podcast about the extra cap versus osteotomy cruciate. That's going to happen at some point, I'm sure. That one's 7 hours long. Okay. But we've kind of gone between. So we've infection. We've got meniscal tear. We've touched on whether or not we feel that the TPLO is appropriate, and we've achieved stability. Obviously, if you have a meniscal tear that you're diagnosed at surgery and you've done your TPLO appropriately, there could still be a chance that dog is the one that is going to benefit from physiotherapy because it's got that instability, because the meniscal loss is going to create instability. And what it might, ultimately there's nothing you can do about that. You've lost your meniscus, and so now you've got a little bit of torsional instability and a bit of more prone to doing a draw the thrust that you would not normally get. So there are ones where the result of this is, this dog is still unstable. It might be because it had a meniscal tear, or it might not be, but actually it is appropriate at that point that's the physiotherapy. Get muscle on this dog situation, isn't it? I think. Yeah,
and the dogs that are presenting for a TPLO with chronic injury as well, with marked muscle loss. I mean, we know how much extended recovery they need. They're really 6+ months.
Yes.
Trying to build up that muscle mass, and they are slower and really niggly on that through an extended recovery.
Yeah. So I think we've gone 3 out of our list, and the list is now getting kind of to the slightly rarer, perhaps. Tendinopathy is challenging, isn't it? You often will see on a post-op X-ray of a TPLO patient that the patellar ligament tendon looks a lot thicker than it did originally, but that's not always a problem. I think there are times when it's kind of convincingly is.
Yeah, definitely. You can often pick that up. You palpate it and give it a squeeze, and the dogs where it's upsetting them, it's quite obvious a lot of the time.
Yes.
Like they do not like it.
That was where I was leading.
Yeah.
I think you can. That is one of those diagnoses where you in the consulting room you can say, is it sure, patellar ligament's thickened. but is it painful? And if it is, I think that's definitely on your list. It's quite challenging to manage, and I don't think you probably can't be confident enough without doing your extra workup, your x-rays, maybe looking at the joint fluid, looking at that side of things.
Yeah, it's hard to jump in without ruling out some of the much more common complications and just assume it's a patellar tendonitis and manage that way.
Yes.
I don't know what you find. I find it's often the dogs that owners are probably not constrained as much in the post-operative period.
Yeah, potentially.
And then trying to extend that recovery because it's still painful and get them to slow down a bit. It's always a challenge.
And it is, and that's why you need the diagnostics, isn't it? Because if you haven't done those, you're going to because essentially with patellar tendonitis there is no real treatment. It's just rest and time. And already the reason you're talking about this is because this is a dog who's not doing very well at 10 weeks after surgery or whatever time it is. So you're actually you need to be confident that you've not missed anything before you can sit back and go, there you go, it's patellar tendonitis, rest up, anti-inflammatories.
Yeah, or otherwise you're essentially managing a dog for patellar tendonitis that has a meniscal injury that you then revisit 6 weeks later and sort its problem
So
out.
there is a point, and I think the point is it's difficult to define. There is a point where the investigation is required.
Yes, yeah.
And you can't really call your patellar tendonitis in the consulting room, although you can have a really good, feel that it probably is that.
Mm-hmm. Yeah, definitely.
And we mentioned fibular fracture as well. That happens as well. It's not that. It happens. It happens at surgery, obviously, and intentionally sometimes because you can't rotate.
Yeah, and look at most of the ones that I've had have happened post-operatively, and they've just been an acute onset lameness, sort of 2 or 3 weeks later, and you can see it on radiographs. It's painful on the lateral side when you just palpate there. They tend to respond reasonably quickly if you're towards the end of the recovery period, often extend it a little bit, but it's still appropriate with the the middle of their recovery with leash walking and restricted activity. Yes. It slows them down a bit, but I find it doesn't really alter their outcome or dramatically extend their recovery.
I think that is true for the vast majority, although I've had a couple that have fractured fibula and then the implants come loose.
Okay.
And they were an extremely aggressively bouncy lunatic dogs that unfortunately got some rock back as a result. And we haven't really touched on rock back, which is the change of tibial plateau angle after the surgery, so you don't end up with what you intended to get. The reason I haven't really touched on it is because if you're using locking screws, rock back these days is really unusual. And if you're doing a TPLO, I would very, very strongly recommend using locking screws for that, and I think most people do.
Yeah, I'm not sure if you can buy the old implants. Can you?
I think you can.
Yeah, you still can. It's still available.
You can torque the triangular plate.
Yeah.
And, I think it's available, but I don't think there's any real reason to use those. Again, it's not gold standard, and the plates are available, and it's not prohibitively expensive. But that's the reason I haven't really talked about rock back, because it does occur, and it used to occur, and it used to be a thing that people talk about a lot. But when the fibula has fractured, I've had dogs that have rocked back and shown a little bit of movement in that moment, and you go, oh, okay. And it's whether or not you choose to do anything about that obviously depends on how the patient goes as a result of that.
Yeah. If they're clinically doing well, you look at it and hope it's not a problem, and you move on.
Yes, exactly. So I think we've covered, I'm hammering this point home, but I think we've covered the most common likely reasons why a post-op patient is not performing well with the TPLO. And the reason I just think this is just worth dedicating a moment of time to is that obviously TPLOs are a very common orthopedic procedure, the by far the most commonly performed orthopedic procedure. It's done in general practice and it's done everywhere, visiting surgeons or in-house surgeons as well. And it is something that we see a lot of where it's not the opportunity to jump in and make a difference for that patient that's probably not been taken, as early as it might have been, because we just need to look at it and go, is that correct or not?
Yeah, and as we touched on earlier, some of those complications, it can get a bit grey as to where you're directed with the investigation, and not knowing what's what, and you can often get led down the wrong pathway. and, getting that list of differentials right and your investigation and your plan, just going back to the basics, it's the top differentials, and you need to rule those out.
Yes.
Yeah.
And obviously, if we're not confident in in a GP setting, we're not confident in taking those steps, it's not inappropriate to get an opinion with a specialist and go, look, we did this surgery here. I'm just not sure if it's right or wrong. It's going okay. Have it assessed.
Yeah, definitely. Yeah, we get that all the time. Yeah.
So I hope that's cleared up approach to that particular problem, which I think is, as we said, very common. Thank you so much for watching and listening to us today. I hope it was useful. Obviously, quite a niche topic, but at the same time, very, very common. So if you've had any more questions regarding TPLOs, anything you'd like to get in contact with us, we'd love to hear from you. And if there's anything you would feel we could address in a future episode, that would also be really helpful. So if you'd like to contact us, I'm reading now from my document. You can contact us at education@penvetreferral.com.au. Thank you very much.
Thank you.
And that's a vet wrap. Join us fortnightly for these podcasts. You can access them through our YouTube channel, Vet Education Hub on the Peninsula Vet Care Emergency and Referral Hospital website, and all other platforms that you can source your podcasts.